Okay, now we can see screen. تفضل دكتور
So
حسام start.
I am so sorry about this technical problem. آه، فان شاء الله نعوضها باذن الله تعالى. طيب my slides is clear now دكتور صباح صح؟
Yes,
طيب
yes,
Yes,
everything is
yes
okay
دكتور
now.
تفضل.
اوكي ان شاء الله باذن الله. So causes and trigger for right ventricular failure in ICU. We have a lot of causes actually facing us in clinical practice. Is the maybe acute or chronic. Acute can be classified into either RV decrease of RV contractility, RV volume overload, or RV pressure, and also chronic like this. The most important or the most clinical scenario is pulmonary embolism, which represent about 50% or 60% of cases we faced as right ventricular failure secondary to pulmonary embolism. It is acute. However, in chronic situation in our institute, we are facing right ventricular failure second to severe pulmonary hypertension, and then this patient can be admitted to ICU. In practice, we have three common pathways for RV we are facing in ICU. In matter of time, we have acute, subacute, and chronic. In case 45 years old female patient in surgical ward, day 3 post-operative after radical mastectomy. Now she is complaining of chest pain and arrested. What is the most probably the etiology of this? Dr. Ahmed, check the chat box, please. Dr. Ahmed. So the most common etiology for acute like this is the pulmonary embolism. So the second scenario is the subacute. Patient 21 years old male patient, day 3 after intubation, second to ERDS and severe community acquired pneumonia. Now he is hypotensive, fluid not responder, increased liver enzymes, and hyperlactatemia. This is another scenario we are facing, is the what's called provocative or subacute right ventricular failure secondary to ERDS and second to mechanical ventilation by hyperprotective strategy. Finally, the chronic right ventricular dysfunction, and we will admit it as acute on top of chronic. The most common pathway for this one, admission from pulmonary hypertension clinic or from pulmonology referral, is like scenario 55 years old female patient, medically we saw this patient in medical ward. She is admitted to hospital from pulmonary hypertension clinic for further workup for pulmonary hypertension. In hospital, she developed HAP or hospital acquired pneumonia. Now she is hypotensive and hypoxic. So the most common pathway we are facing as regard the RV failure, either it is acute, subacute, and chronic. What is the triggers for RV failure? The most important triggers for RV failure is ERDS, either because hypoxemia or hypercapnia or even the mechanical ventilation. I will go through some anatomical and physiological difference between RV and LV. Actually, the RV is very thin. Why thin RV? Because this RV or this chamber facing very low pressure. It's the pulmonary circulation. Very thin, very sensitive, taking supply of coronaries in systole and diastole. The response of RV to hypoxemia by vasoconstriction. This is different in the LV. In the LV, the left ventricle is high pressure, thick wall, receiving only coronary perfusion only in diastole, and the response to hypoxemia of the coronaries by or circulatory by vasodilatation. Another physiological concept which called the RV systolic perfusion pressure, which is the difference between systolic blood pressure and the pulmonary artery systolic blood pressure. And this is very important to emphasize that to improve RV systolic perfusion, either to increase systolic blood pressure or to decrease pulmonary systolic pressure. So one of our goals in the RV resuscitation to increase systolic blood pressure. In the same time, we are aiming to decreasing pulmonary artery systolic blood pressure or pulmonary hypertension. Another physiological importance notes about RV, the Starling curve. The RV is falling off the Starling curve. What's the meaning of this one? LV, when increasing the volume here, I will. When increasing the volume, this leading to increase the contractility until some point, more increase of the volume or more increase of left ventricular end-diastolic pressure, no further increasing of cardiac output. However, in RV, because of the RV is very thin and very liable for dilatation, increasing of the volume to a certain point after this one, leading to not only a plateau of cardiac output, but also decreasing of cardiac output. Finally, because of falling from Starling, we have increasing of CVB, and from other side, because of dilatation leading to shift of the interventricular septum to the left, leading to decreasing the LV diastolic volume, and so decreasing the LV pressure and decreasing blood pressure. So we have two. We have increasing of CVB and decreasing of MAP. Both of them leading to what's called decreasing of perfusion pressure. Another very important physiological note is the decreasing perfusion pressure. Perfusion pressure of the brain or the heart or the kidney or the bowel, depending on the difference between MAP and CVB for the brain, diastolic blood pressure and CVB for the heart, MAP and CVB or intra-abdominal pressure for the kidney, MAP or the CVB or intra-abdominal pressure for the intestine. So increasing the CVB, what happened in the RV, and decreasing the MAP, both of them leading to what we calling decreasing organ perfusion pressure. For the brain, if that happened, leading to decreased conscious level. For the heart, leading to cardiac ischemia. For the kidney, leading to decreasing urine output and renal shutdown. For intestine, leading to bacterial translocation, and these patients are very prone for sepsis. What's called spiral of death? What's the meaning of spiral of death? Spiral of death meaning once the RV is dilated, this leading to shift of interventricular septum, and this leading to decreasing of cardiac output. دكتور أحمد؟
ايوه يا دكتور حسام اتفضل.
Okay. طيب. Decreasing of this leading to vicious circle. Another spiral, increasing or RV insufficiency, or leading to dilatation of the RV. This leading to stress on the RV, and this leading to RV myocardial decreasing myocardial perfusion, and this leading to more RV ischemia and more RV dysfunction. The third spiral is RV dilatation leading to tricuspid annulus dilatation. This leading to right atrial enlargement, and then leading to atrial fibrillation and arrhythmia. This leading to mandate to give some beta blockers, and beta blocker leading to more RV dysfunction. Finally, the last spiral of death is the bowel ischemia or bowel hyperfusion. This leading to bacterial translocation, and bacterial translocation leading to systemic hypotension, and systemic hypotension mandate to give vasopressors, and this leading to more RV dysfunction. So our rule in intensive care to avoid the patient to slip into this spiral of death. Diagnosis. Actually, the diagnosis may be clinical or laboratory or catheter or echocardiography. I will start first of all by clinical, and I will use the movie of Suspicious Mind, because RV diagnosis needs suspicious mind. We should think about clinically when there is signs of hyperfusion plus clear lung and systemic congestion. Systemic congestion means, as first of all, signs of hyperperfusion like what? Patient is cold, mottled, increased lactate level, decreased urine output, clear lung because it is not secondary to LV, and systemic congestion to the brain, leading to decreasing of conscious level, increasing of liver, congestion of liver leading to increased liver enzymes and increasing bilirubin, congestion of the kidney leading to decreased urine output, and intestine leading to bacterial translocation. This is clinical. However, radiologically can be by X-ray or by CT. Radiologically by X-ray or CT, X-ray is, as we shown, there is dominant or prominent pulmonary artery, peripheral hypovascularity, and also right descending pulmonary artery dilatation. In the CT, there is increasing of the pulmonary trunk diameter, even it is more than the aorta. And also here in the right bronchial, right pulmonary trunk, there is shifting to the midline as the level of carina is what's called the carina crossover. And in the heart, we show the RV is markedly dilated, and shifting of the septum towards the LV. In the liver, there is systolic or diastolic reflux because the filling of the right RV in the diastole. So in diastole occurring the different is there is contrast reflux into the hepatic veins. It is not sensitive, not specific, radiological. For lab, we have Dr. Ahmed.
ايوه حسام واضح كل حاجه everything is good go on.
طيب انا برضو I need 2 minutes to adjust some points in the PowerPoint because it is fixed. يعني انا my screen is clear صح؟
Yes دكتور it's clear.
Okay. Stop sharing. I will stop sharing and then I will share again.
Okay no problem.
I'm sorry for this one.
No.
That's about
دكتور حسام that's you means ال RV failure we it's not only depending we can diagnose it clinically also not only
yes,
by
I will mention
the
it.
echo. Yes.
I will mention it, Dr. Ahmed, in details. But first, I want to fix what happened in the slide because merge video and I think
يعني
something.
this is very important not only depending waiting for the echo or for catheter. No, we can diagnose it clinically and also by the
Diagnosis,
Yeah.
as I mentioned, start from clinical, then
Yeah.
radiological. The radiological suspicious by CT and by X-ray. However, the most important, I will continue, Dr. Ahmed, بعد إذنك. However, the most important sign in the X-ray, what is this? The most important sign, Dr. Ahmed, as my colleague, is negative. If X-ray is completely normal and the lung is very by auscultation crystal clear. However, if the patient is hypoxic and tachycardia, this is the most important. It is a negative sign. X-ray is completely clear and the patient in shortness of breath. So it is not LV. It is RV. Another method of diagnosis is the laboratory. Actually, lab can be classified into after forward heart failure, which increasing cardiac output, and backward lab and forward lab. Forward lab like what? Patient is hypotensive, hyperfuse. This leading to metabolic acidosis, leading to hyperlactatemia, leading to decreased central venous saturation. Backward, it is a congestion, صح? Congestion leading to what? Liver enzymes to be rise, leading to kidney function or acute kidney injury and bacterial translocation, as we mentioned. There is a new concept, what's called the lactobolo reflex. It is, I think, published 3 years back about lactate level. All of us, and I want to share it. It is my experience in lactate level. Most of our colleague and most of our residents, when he found lactate is rise, I mentioned now lactate, one of signs of RV failure. So one of rapid response, lactate is rise, give bolus fluid. Lactate is rise, give bolus fluid. This is called the lactopolar reflex. Is firstly published in 2019 by Paul Mark, and he found more fluid, more fluid increasing in lactate. This is in situation like what? In like our situation. So when you are treating patient, shock the patient, and giving fluids, and the lactate not improving, think ischemia. Stop fluid, do your focus, assess the RV, LV, and even search for hidden sources of sepsis. If everything is okay, think ischemia. So if lactate is rising, however, bolus, think ischemia. How? Maybe you have the ongoing cardiac ischemia like LV or RV ischemia. Maybe we have ongoing bowel ischemia. We found it a lot of cases. Patient shocked, had a history of AFib. Now she is complaining of shock, refractory to fluid boluses, and the lactate is rising. However, the fluid resuscitation. I should think ischemia. Ischemia may be LV ischemia, RV ischemia, bowel ischemia, or even in some cases, like in trauma cases, compartmental ischemia, hidden ischemia, like limb compartmental or abdominal compartmental syndrome. ECG also can help, but it's also, again, it is not specific and non-sensitive for pulmonary embolism. The most common is S1, Q3, T3. It is not sensitive, not specific. Maybe signs of RV strain like incomplete heart block or depression of T wave in the pericardial right leads. But the most common, it's very important, the most common sign of RV failure is sinus tachycardia. So not the new onset AFib, however, it is common. Not signs of RV strain, however, it is common. Not S1, Q3, T3, because it's a very common question in the board exam. Pulmonary artery cath. Pulmonary artery cath, now I think in the last 10 years, I inserted only 1 or 2 pulmonary artery caths because all of evidence against to use it in critically ill patients. Because of what? Difficult to introduce, poor tolerance and leading to arrhythmia, maybe sometimes rupture of the balloon. Most of our patient is coagulopathic, hemodynamic instability, no skillful physician to do it. So all of that, and behind all of that, no evidence supporting pulmonary artery cath. But I think in the next 10 years, the pulmonary artery cath will appear again. It's very important. It is differentiate between acute and chronic, and also can differentiate between the etiology of the RV. It is isolated RV failure, or it is RV secondary to LV, or secondary to lung. طبعا I'm sorry for this technical issues. Echocardiography, again, echocardiography. طبعا I am one of fans of echo in intensive care and the point of care. Echo very important in RV failure, not only to showing thrombus. It's very rare to see thrombus in the heart, or what's called a clot in transit, but can differentiate between acute and chronic. Very important. If the RV is thick, it is chronic. If it is thin and dilated, it is acute. Severity of tricuspid regurg. If the tricuspid regurg or gradient pressure around the tricuspid valve is less than 46, it is most probably acute. More than, it is chronic. Pulmonary artery acceleration type, if less than 60, it is going with acute. More than 105, going with chronic. 66 sign, which is a submission of both or both. It is pulmonary artery hypertension less than 60 and the pulmonary acceleration less than 60. McConnell sign, which is pairing of the RV apex and poor contractility of the RV. Another very important help from echo is that to differentiate not only acute and chronic, is this RV related to volume or to pressure overload? In volume overload, actually, we found flattening of the system of the septum in systole. However, it is in diastole. However, in pressure overload, it is in systole. So again, hypertrophy and systolic septal flattening is the signs of pressure overload. However, dilatation and diastolic septal flattening, it is a sign of volume overload. The cause echo can sometimes showing a clotting transit. Dr. Ahmed? Dr. Ahmed?
Yes, everything is clear.
I need 5-minute breaks. I want to fix some issues in the PowerPoint, please.
Okay, no problem. طبعا the RV failure is a very important topic, especially in critical care. And also, I want to, I have a lot of questions for Dr. Hussam, especially the intubating the RV failure patient. We are facing a lot of problems, troubleshootings with the intubating RV failure patient, especially in crashing patients, and you want to intubate the patient as soon as possible. And in the same time, there is a lot of problems we are facing when we are intubating those patients. Very important by the end of this lecture to have a good idea about how to intubate the RV failure patients, how to adjust hemodynamics during intubation, what are the problems, how can we deal with the problems we can face. This is all of these issues very important. Thank you, Dr. Hussam, for the presentation, and I hope you can, inshallah, go on.